This was the case referred from respected senior, and I am very thankful that he had faith in me. Case young girl with left ovarian abscess with plastered abdomen. Entire pelvis was packed with bowel adhesions, with partial bowel obstruction due to adhesions where one can very easily appreciate the post-obstruction pouch formation.
So as you can see, this is a case where you cannot see the uterus because uterus is completely covered with the sigmoid colon. What we are trying to do is trying to separate the rectum from the toes of the uteri, that is posterior wall of the uterus, right sided tube, and ovary is comparatively free. So what I am holding, that is the outpouching of the rectal part of the bowel, which is formed because of the partial obstruction at the level of the rectosigmoid, which I'll show you later on. So right now we are using the suction and the laparoscopic shearer to separate the rectosigmoid from the uterus with the combination of the blunt and sharp dissection. This is left side tube and the round ligament, which is completely plastered and get attached with the sigmoid colon. So here you can see I am using both the instrument to do blunt and sharp dissection at the same time. Here you can see the content of the abscess coming out from that rent. You can appreciate the blood clots and the pus collection which has formed this abscess, and still it is so much adherent with the uterus we cannot delineate the margin of that cyst. So again we will continue our dissection with the blunt and sharp dissection to try to identify and separate that ovarian cyst from all the surrounding structures, particularly from the rectum and the uterus. And here you can appreciate that round ligament is also get attached with the sigmoid colon. So here we are trying to do sigmoid mobilization. So once we are able to do the sigmoid mobilization, further dissection would be comparatively easy so that we can identify the underlying structure. Here the peritoneum is completely involved and hence it is so much thickened. Here I am trying to separate the round ligament from the sigmoid colon as well as from the ovarian mass. It will give some more mobility to the uterus, and so that we can see the structure in better condition. Here I am trying to separate and dissect the round ligament further, not only from the ovary, also from the fallopian tube that is also adherent and form the TO mass. So here now you can see the content of the ovarian abscess. Still we are not able to identify the complete ovarian cyst. So we have changed our approach. I thought to start with the normal structure, but here you can see this is the sac which has formed due to partial obstruction which is coming in our way. So assistant is holding that pouch of the rectum and I am trying to dissect further down so that I can separate and release the rectum from the adherent part. That will give more mobility to the rectum. First, I have plicated the right adnexa so that one hand will be free and assistant will be able to help me to dissect and give counter traction. Here his assistant is holding the edge of the peritoneum so that I am able to dissect further downward towards the medial pararectal and retrorectal space. You can see this is the hair structure, that is the uterosacral ligament which is also adherent to the rectum. So we have to go in between that uterosacral and the rectal part. Once it is done, now we will continue our dissection on the affected side You can see this is the entire adnexal mass. Here we cannot identify the tube or the ovary separately. So what we will do, we'll dissect the peritoneum. This is the peritoneal fold which is affected and thickened. So first we have to dissect and separate. For that I'll prefer to go in retroperitoneal area. Here you can see this psoas muscle and genitofemoral nerve, which is again landmark that will give us idea about the major vessels. I am dissecting the peritoneum further so we can make the sigmoid column further free and mobilize it. Now you can see I am going just below the round ligament so that I can dissect further and make some anatomy clear to understand the condition and make the TO mass free from the lateral margin, so that we should avoid any injury to any major vessel as well as to the ureter. So I am dissecting and making free that TO mass from the lateral surface. You can see this is the lateral margin of the TO mass, which is also attached with the obliterated umbilical artery as well as to the round ligament. So in such cases we can compromise the round ligament first, then we can suture it later on. So we decided here to compromise the left sided tube and ovary. The concern for the salpingo-oophorectomy of the same side was taken already pre-operatively, as MRI showed this structure is full with the pus collection. So we had some idea about the condition, and here you can appreciate that there is no ovarian tissue which is healthy. So the only option we are left with, that is removal of the left sided tube and ovary. This is the sigmoid colon. What we are trying to do to make it free, to mobilize it further, but as you can see there is the partial obstruction at that particular area, so we could not mobilize it properly. So we continued our dissection in the medial pararectal space. Here you can see ureter is seen. Now still it is affected and covered with the fibrotic sheath, so proper ureterolysis will do later on. Here we are trying to separate the peritoneum, which is grossly affected, and we will separate it from the ovarian mass as well as from the lower part of the sigmoid and from the rectum. So you can see here we got some space to dissect, and now you can see a part of ovary. You can appreciate by the texture and color of the ovarian tissue. We are heading towards the salpingo-oophorectomy. So almost lateral attachments are cut and separated. Now only thing which is adherent is to the rectum. We are trying to dissect it with the blunt and sharp dissection. Once we will cut this band, now this is free and we have removed that part. This is all, multiple raw area and bleeders that we will take care, and some of bleeders will stop its own. So no need to cauterize each and every bleeder, it will stop. If you think it is bleeding a lot, you can put a gauze piece that will take care of that bleeder. Now it's time to dissect and identify the rectovaginous space, which is very a crucial step. Otherwise you won't be able to mobilize the rectum completely, and without mobilization of the rectum and separating the rectum from the uterus, it is not possible to give justice to rectal adhesion. If we are planning to do a sigmoid or the rectal segmental resection and anastomosis, for that we have to mobilize this bowel completely, and this is the point of the obstruction. You can appreciate that. Now we are continue our dissection further down at the area of the rectovaginous space, but here because of that dense adhesions secondary to that infected pathology, we are not able to get easily that plane. So we are taking some risk, compromising serosal layer of the rectum and dissecting further down so that we can enter that area. And now you can see we have got some space that is bleeding because we are into the serosal layer, but as it is not accidental entry into the serosal layer, it was planned, so we are not much afraid or tense about that. We continuing dissection in that same plane, and now we got some plane into the rectovaginal space. Here assistant is introducing the rectal probe to check the point of the obstruction. Now it's time to do ureterolysis, which is so much difficult. In such cases, you have to be very careful of two things. One, to get proper plane or avoid any injury to ureter, and second thing is you have to be very careful about the thermal injury because it may cause fistula. You cannot sometime identify at the same time of the surgery, but the fistula may develop even after 1 or 2 weeks, so you have to be very careful. We are removing remnant of the ovarian cyst. So now it is ureterolysis proper. We have to remove this peritoneum which is grossly affected and covering the ureter, which is causing a great compression on the ureter. So if we are not removing this thing, it will definitely cause hydroureter and hydronephrosis. You can see the gland that shows that it was endometriosis only, and that abscess has formed secondary to endometriosis, which was left untreated. Now here I am using cold scissor. As I have mentioned, I don't want that energy has passed to the ureter and it may cause later on a fistula. So it is always better to use a cold scissor in such cases. There is no heroism in saying that I am not afraid about any energy source, I can use any energy source. Here the important thing is the safety of the patient. So you have to switch your instrument according to the condition of the disease. So again I am using a shearer when I am trying to remove that affected peritoneum, and part of the uterosacral ligament also was compromised. Again I switched with the cold scissor when I am working very close to the ureter. Again it will give more plane compared to any energy source. And now you can see ureter is completely free now. Now we are left with just remove the remaining part of the affected wall of the ovarian cyst, and that all the specimen we will remove through the posterior colpotomy. Yeah, some people may think that in young girl why to do colpotomy, but I am using this method since last 10 years and I never encountered any complication or complaint like dyspareunia in any of my patients. So I am very comfortable and confident about the posterior colpotomy. It is a very good method. It will give it will serve your cosmetic purpose as well as it is very easy to remove a big specimen as well. Air test was done to rule out any leakage or injury to bowel. It was not there, and this is the end of our surgery. We have removed that disease completely, and partial obstruction was relieved after 2 weeks. When we did repeat scan and CT scan, there wasn't any obstruction anymore and patient was passing stool. Patient is completely pain free, and you can see this is the all pararectal spaces which we have dissected. Here you can see the area where ovarian cyst was present. It is now free. Ureter is also free. Thank you so much.